Psoriasis tends to have a bimodal age of onset, so it tends to present either in the early 20s and 30s or in the 50s or 60s. And so you can imagine going your whole life without having this chronic issue and then ending up getting to 60 and then all of a sudden having this severe chronic inflammatory state. And so that's always more concerning. But that those patients may have other comorbidities that help it to be unmasked later in life. The age of onset does factor into treatment choices. So if we have a pediatric population, we are going to consider biologics differently. There are some that are not FDA approved for the pediatric population yet. So at that time, I would consider more skin-directed therapy, and it depends on the severity of the patient. With my pediatric population, I try not to be too invasive with them because I don't want them to be too traumatized from their encounter with me or with dermatologists in general, because psoriasis is a chronic disease state that they will have indefinitely and be suffering from indefinitely. So I don't want them to be too traumatized from our encounter with injections and needles and things like that. So I prefer to do things like phototherapy and topical psoriasis medications instead in my pediatric patients, unless they have moderate to severe and the topicals and the phototherapy isn't cutting it, then we would choose biologics that are FDA approved for the pediatric population. And the same goes for our geriatric population. Of course, we do not want to immunosuppress those patients too much. So the older medications such as methotrexate, et cetera, I would be more cautious with and look at more targeted medications such as the IL-23 inhibitors for that population.